Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCases. There's a culture problem in medicine. 70% of us are disengaged. More than 50% contribute nothing to our departments outside of our clinical work. And more than 15% actively work against a healthy culture in our departments. What makes an emergency department run like a well-oiled super machine with staff that find meaning in their work and who are grateful for doing their work? Well, there's individual skills. There are team skills, there's the admin, and then there is the oh-so-important culture which permeates all of these and can make them great or can drive them into the ground. The culture of an ED can make it or break it. This podcast is going to be quite different from most of the other EM Cases episodes. We're going to chat with 2 brilliant physicians who have a deep interest in the culture of medicine to explore what culture in medicine is, why culture is so important, and then we'll drive home 5 solutions to improving the culture in our departments so that we can love our work, we can love our departments, we love taking care of our patients, and probably our patients will have better outcomes. Well, these 2 guests are Dr. Peter Brindley and Dr. Leon Byker. Welcome to EM Cases, Dr. Brindley, and welcome to EM Cases, Dr. Byker.
That may be the single best introduction I've ever heard to a podcast. You've nailed it. Both the issue, the concern, and hopefully the right mixture of optimism and realism. Bravo.
Yeah, thanks for having us.
So just to familiarize our audience with who you are, Dr. Brindley, could you just give us a little bit of a background in terms of what you do professionally and how you got interested in the culture of medicine?
What am I? I'm an ICU doctor and a professor at the University of Alberta and University of Alberta Hospital in Edmonton, Western Canada. And I don't think you can do medicine for 30 years, as I have, without being interested in the culture at some point. Anton, yours and my paths have crossed many times. We've shared many podia together. And you know what? We're both interested in individual performance. We're both interested in how the team works together. We're interested in the institution. And you can't go on that journey without at some point saying the culture truly matters. And that starts with, well, what the heck is a culture? What's a good one? What's a bad one? And can you move one towards the other?
Excellent. And Dr. Byker, could you tell us a little bit about your training and background and how you got interested in the culture of medicine?
I'm a hybrid physician, so 50% of my training was in South Africa. The other 50% was, I was fortunate enough to train further in Canada. Training was at the Chris Hani Baragwanath Hospital, which is one of the biggest hospitals in the Southern Hemisphere. And by sheer volume, we really were trained really, really well. Insofar as culture goes, I think for me, it is really about my personal journey throughout medicine thus far and really evaluating why I do what I do, how I got there, and how I can then, function within a team with the underpinning of that it's not set in stone, that fortunately things can change over time and that things should change over time.
Absolutely. I think there's maybe this misconception that the culture of a place is just the culture of the place and it's fixed and it can't be changed. And hopefully by the end of this podcast, people realize that that is not exactly true and that there is hope to change your culture for the better. But before we get into any of the stuff about culture and solutions, we really need to define what culture is. Dr. Brindley, how do you define culture in order to understand why it's important in our collective lives as physicians?
Yeah, and we have to start by trying to make a fist at a definition of this. And it's difficult. And in fact, if you look it up, it says this is difficult to define. But basically, it includes more than just knowledge and manual dexterity and the people. It includes your values, your beliefs, your behavior, what's acceptable, what's not, so that doesn't seem too opaque. I often fall back on Gert Hofstede, that's Hofstede, for those that want to look it up, and he defined culture using 5 indices: power distance index, me versus we, assertiveness, uncertainty, and our long-term versus short-term approach. So in other words, if I get a bit more granular, how big the distance is between the most senior person and the most junior person in any totem pole, and how much those in the positions of power believe it's preordained and they deserve it, and how much those in the more subordinate positions accept that. And by the way, I'm not saying one's right, one's wrong. I'm saying this is how they're defined. Discuss. The me versus we is the sort of how collective you are versus individual. Assertiveness, how much you're expected to be assertive versus how much assertiveness is tolerated. What sort of uncertainty you will allow. And I mean, this comes up at conferences all the time, whether people want mandates or they just want to follow an algorithm, or whether people say, no, the underpinning physiologic principles and the N of 1 will guide, my clinical acumen will guide, and then long-term versus short-term. And I'm an ICU doctor, you're an emerge doc. You can imagine that all of these things play into what we do. And I think one of the reasons culture is so important and so interesting is because medicine is culture, and it's often just culture sped up and distilled and in more extreme circumstances. So what we do is interpersonal and requires communication. The term just means making many one and bringing people together. And the acute care environment just means you have to do these under haste, pressure, sleep deprivation, resource limitations, et cetera, et cetera. And that's why we cannot not look at culture. We can't shy away from it.
Yeah, I mean, I think part of the importance of defining culture is to have listeners assess where they are in their departments on each of these scales. By defining culture in this way, it's a really good start in terms of people being able to reflect on where they are on all these scales and then how to improve their culture.
Culture change occurs over a time scale that most of us are not built for. It occurs over a generation, over 20, 30 years. And that's one of the reasons we desperately need to keep the wise gray hairs in our department. We need that experience, and we need people who've gone on that cultural journey. And both Emerge and ICU have been guilty of sort of working people half to death and then jettisoning them the minute they show any fatigue or frustration.
There's so much packed into what you just said. I don't even know where to start.
Well, I just took a big sip of tea, so I feel somewhat more energized now than we did when we started.
All right. You know, it's interesting that you say it's from the airline industry that these definitions were developed. I think most of us know the classic story of why, I can't remember which airplane was it that crashed.
KLM.
Yeah, KLM. The first part of the definition is the power differential, and the story that only because there was a power differential between the co-pilot and the pilot did the plane crash, because the co-pilot knew exactly what was going on, knew exactly what to do to fix the problem, but because of the power differential between the co-pilot and the pilot, he did not go ahead and take action and did not inform the pilot adequately to the problem, and the plane crashed. So yeah, we owe a lot to the airline industry, for sure.
Well, and they also introduced the ideas of teamwork and task work, that, you know, there's a difference between just getting something done and also building the culture you need within your environment to not just get a finite task done, but to get all tasks done and to keep people resilient for the next patient coming in.
Yeah, and the whole communication thing that the airline industry started, that Starbucks takes on, that just calling back the order that was just asked for to ensure the closed loop communication and all of that.
Insofar as culture goes as the collective ethos, certainly coming from what you guys have just been talking about and so on, I mean, the airline industry does not have 30 years to change a culture. We're not a victim of our culture. And I think we sort of living bricks within a culture. we can make sort of changes and hopefully over a shorter period. But I think it's just important just to realize that we're not victims of a culture that's unchangeable.
All right, so that's a little bit about the definition, how we can define culture and why it's important. I want to move on to the idea of leadership versus followership and the importance of followership in all of this. You know, we're planning an EM Cases episode on how to be a great leader in emergency medicine because in many ways we're all leaders and our leading skills can dictate how well we do at work and in life. And a good ED culture is often reflected in its leaders, they say. We talk about leadership skills all the time, it seems, but we need to talk about following, or what we'll call followership. Dr. Brindley, why is followership important in medicine?
Everybody wants to believe they're going to be a leader. There's a leadership institute in Edmonton as part of the University of Alberta, and I believe it took them about 15 minutes to raise the funds to open this building because everybody wants their little Jimmy and little Janie to be tomorrow's leader. And I'm not mocking this in any way, shape, or form. I want my kids to be leaders, but let's define what a leader is. And a leader is somebody who simultaneously takes responsibility but works seamlessly as part of a team and accepts ideas from other people and goes into a situation and assesses not what do I fancy doing today, but how can I make this situation better? And that's how I've tried to raise my children. And you can call that leadership if you want, but it is probably followership. And there are 60 papers written on leadership for every paper on followership. So it has been a neglected topic. The sense is followership truly matters. About 85% of us are probably better defined as followers. And even great leaders, titular leaders, move seamlessly in and out of leadership and followership positions. So an accessible example is there is actually a belief that when a guy like me or an anesthesiologist comes down to your emergency room, Anton, because you call us because you say, hey, I'd like some help with this airway, we may actually subconsciously hope that you fail so that we can just push you out of the way and take over. Rather than what we should do, which is come down and say, Anton, I'm from ICU. I'm here to help in whatever way. What would be most helpful to you? And you say to me, I just want you to be present. It'll expand my cognitive bandwidth. Or you run the drugs, I'll run the airway. Or you do the system 2 stuff, I'll do the system 1. In other words, you do airway, breathing, circulation, I coordinate the team and work on getting you a bed afterwards. Instead, what we all do is our comfortable thing, which is to try to come down and with a mixture of bombast and ego take over that situation. Now, it's difficult to negotiate in real term who does what, and that's why culture matters, because you have to have a culture of safety where people feel safe listening to others or hoping that they will be listened to. But that's what followership is. And I want to give a big shout out to Lawrence Gilman from the University of Manitoba, because he was the one that suggested we start writing about this, and he's gone deep on the topic and is a perfect exemplar. As a general surgeon intensivist, he is not what that archetype personality often comes across as. He is the gentlest, most decent guy, and his secret power, his secret source, is what a decent guy he is, and he commands a quiet respect from everybody. That's what followership is.
So that tells us a little bit about what followership is. Why can followership be sometimes even more powerful and more important than leadership? In your talk that you gave, Dr. Brindley, you showed a video or some pictures of a video that has circulated around the internet 7 billion times.
Indeed.
About the young man on the lawn at a concert by himself who starts dancing. And he's dancing by himself for a couple of minutes.
Errant behavior, right? Weird behavior. Dancing on your own at a concert. Goodness
yeah.
sake.
And then there's one person who joins him. And then the next thing you know, the entire lawn is up dancing and having a great time and enjoying the communal feel together. So could you comment a little bit on the importance of being a follower and being especially that first follower?
Thank you. I'm glad you used the term first follower. Yes, we're Canadians. We know about first followers in our system. Every political party, if they don't have a number two, they fail. And the first follower is very interesting to me because many people don't want to be a follower because it sounds subordinate and junior. So then be the first follower. And some people won't be allowed to be the titular leader. Well, then be the first follower. So I think it's a wonderful node between subordinates and seniors. And again, those are titular terms. We move in and out of these roles all the time. But be a first follower and identify the first followers and find a way of valuing the first followers. Because unfortunately, guys like me who feel comfortable behind a microphone or a lectern, we get too much attention. But most of what holds emergency departments and critical care units together is people who aren't out there tub thumping behind the dais and giving presentations. But we know them in our departments. They are the absolute glue. We've all had people retire where you think, oh my God, it's going to take 3 people to replace that person. Often leaders, but they're often first followers as well. So please be one, become one, grow into that role.
This episode is sponsored by BetterHelp. Halloween lets us have fun with what scares us. But what about those fears that don't involve zombies and ghosts, like a really bad patient outcome, complaint, or litigation? Therapy is a great tool for facing your fears and finding ways to overcome them. Because sometimes the scariest thing is not facing our fears in the first place and holding ourselves back. I've personally benefited immensely from therapy, which helped me face my biggest fears instead of hiding behind a mask. Big fears, not only in my work as an EM provider, but in my personal life as well. If you're thinking of starting therapy, give BetterHelp a try. It's entirely online, designed to be convenient, flexible, and suited to your schedule. Take off the mask with BetterHelp. Visit betterhelp.com/emcases today to get 10% off your first month. That's BetterHelp, HELP.com/emcases.
Communication, when we do it in a simulation, and we talk about SBAR, we talk about the CUS model. I'm concerned, I'm uncomfortable, this is a safety issue, stop. We talk about 4, 5, and 6-step graded assertiveness. You've already referred to the closed-loop communication. So we do talk about communication, but not in these kind of situations. And I always found it interesting when I was training that it would be, hey, Peter, can you go speak to Bed 4's family? When in fact, the family conference in ICU at least may be the most dangerous and nuanced procedure, in inverted commas, that we ever perform in the hospital. But nobody was watching that. I'm trying to stay away from buzzwords, but this is the hidden curriculum, if I can use that buzzword. This is the thing that you model without realizing you're modeling. So when I'm grumpy, that is picked up by people that want my job because they, on some subconscious level, probably think, well, you got to be grumpy to have this job. He's got the job I want. I'll model his or her behavior. That's that emotional contagion, Anton, that you and I have talked about so much. So tough as it is, the medical knowledge you grasp in about the first 10 years of your career, and then a large part of the rest of your career is flying the flag, being a good example, leaving a legacy. And it is these multiple little interactions that we have with people that set the culture. Your colleague, my friend Aaron Sayal, spoke about this at your conference. He talked about better the ball, his idea taken from volleyball, that whatever your next shot is, just make it better than the last shot was. And I'm a grumpy bugger. I'm short-tempered. I'm a polarizing character. And one of the biggest things I will have to stay cognizant of in the last third of my career is, dial down the bombast. Don't go to every argument you're invited to. Don't feel the need to run out into the middle of traffic and start directing all the cars. That's one of the sort of cultural touchstones that you pass on to other people. So we're all influencing the culture all the time. The biggest part of culture is communication, which is where the question started. Now, there's also verbal communication, what you say, paraverbal communication, how you say it, how loud your voice is, your inflection, such that, I could use some help can sound like a very gentle comment. I could use some help can sound like a very aggressive. I could use some help can sound passive aggressive. Why isn't anyone helping me? Nonverbal, so your facial tics, how you look, that's incredibly important. And in fact, if somebody says something that sounds nice but with an angry face, people will pick up on the nonverbal before they'll pick up on the verbal. Now, the flip side of that is it's incredibly important to address nonverbal, because we've spent most of the last 5 years wearing masks and goggles where you can't see people's nonverbal. And we do so much coordination of care in this country via the telephone, so it has a loss of nonverbal communication too. So we have to learn a way to teach that. And then there's heuristics. Then there's the last interaction you had with somebody. There was an emergency department on the west end of this country, and they had some airway issues, and some people went in to examine them. And they asked the emerg doc, just out of interest, how come you didn't ask for help? And rudeness is an incredibly iatrogenic thing, both giving offense and taking offense, and both the afferent and the efferent loop matter. But it's an incredibly iatrogenic thing. And this person said, you know what, I didn't call for help because last time I called for help, they were really mean and patronizing. And a lot of us said, yeah, fair enough, I get that. Rudeness is iatrogenic. And we said, just out of interest, or they said, just out of interest, when did you last ask for help? And they said 10 years ago. And that's the profound effect. So yes, we've got to turn culture around in less than 30 years, but please also understand you can flip over the apple cart in less than 10 minutes.
So I like that kind of dividing communication into what you say, how you say it, and the body language. The question that comes up in my mind is, how do you train for this? How do you train people to communicate better? How do you train people to, yes, ask for help? How do you train people so that they know what to say, how to say it, and body language, which is a thing that, we've carried with us our whole lives in various ways that I would imagine would be very difficult to change. Any thoughts about training for communication for trainees and for staff physicians?
I have lots of thoughts. I'll try and distill them down. It's not just going to be a weekend course. It's going to be a commitment throughout your career. Having said that, a weekend course wouldn't hurt. That's how you get started on POCUS, and then you commit to ongoing training. So it's no different than anything else. It is, walk the walk, talk the talk, all that kind of stuff. I realized early on that my career would probably be divided into learning, earning, and returning. And so if you mix your career up like that, where you say some of this is about me learning new ideas, some of it is about me giving back to the system or being a better follower or working out what the system needs from me. So this is just part of what you have to do as a doctor. And that's why it doesn't end once you've learned all the latest drugs. It's actually got to be an internal commitment. And that includes a lot of reflection. And that, by the way, includes a safe culture where you can both give feedback and take feedback. And we're in a tough situation where most people are so prickly or beaten up that they're not open to hearing feedback, me included. And simultaneously, we've moved into a culture where it is tough to give people forthright feedback, let's be honest. So our afferent and our efferent loop are difficult, which is why so many things are seen as rude and offensive. And there's an old model of 4 voices, 4 sets of ears, that basically the listener cannot force the way that the speaker says it, and the speaker cannot force the way that the listener hears it, which is why, as I say, you can say something like, I could use some help, and you think you said it in a certain voice that was quite gentle, and the person can say they heard it in an atrociously aggressive voice, and vice versa. So we need to look at the afferent loop, the efferent loop, build a safer, more just culture where people can give feedback, where we're not all cats on a hot tin roof. I was on call last night with no beds in the ICU and a very busy emergency department. And the reason we got through the night safely was a bit of dumb luck, a lot of commitment, and people who had developed relationships over years, phoning each other and doing the old sort of, oh, hi, Pete, I'm glad you're on. Can you help me? Oh, Craig, I'm glad you're on. These relationships were in place. And you know what? We're so busy that we've lost time to build those relationships. The softball tournament was not about establishing who was the best softball player. It was about building the team. going for a pint on a Friday afternoon may not be everybody's thing. I completely get that, but it did serve a purpose. But, do we still go for a cup of coffee when it's quiet, or do we scurry off to our offices and do something that we think is more earnest, or go to a meeting rather than just build the team culture?
The importance of relationships really segues very nicely into what I want to talk about next, which is community and teamwork. In North America, it seems to me that we value individualism and status to such a high degree. And I think partly because individualism and status has been such a sort of centerpiece for North American culture in recent years, I think we all really crave community and teamwork. During the first week of my medical school years, I remember I was invited to this big party. It was around a campfire with all the medical students. And there were a whole bunch of people who brought their acoustic guitars to have a nice campfire sing-song. And my wife was there as well. And she just could not get over how there were probably 8 or 9 different people singing different songs and little groups of people singing as loud as they possibly could to to drown out all the others. My wife said after, medicine doesn't really attract people who are good team players, does it?
What an insightful woman.
This brings up, the idea of teamwork, and you've already touched on this before. I think that there's many of us who are not geared towards teamwork and community, and our culture, as I say, really does stress individualism and status.
Let me dive in and amplify and take it a bit further. Teamwork's not just others doing what you tell them to either, and that's one of the confusions. The leader says, come on, we need teamwork. You do this, you do this, you do this. There's a bit more to it than that. And the problem is if it goes too far the other way, you can have diffusion of responsibility. There is a difficult dynamic middle ground between not just bossing people around, but equally stuff needs to get done. There's a fabulous book called The Status Game. And the argument is that we're all playing the status game all the time, and we're not even aware that we're doing it. And that sounds like you're 8 people trying to drown each other out with their guitars. And if that isn't that typical of human beings, that we sort of bring the guitar along because nobody could ever dislike the guy playing the guitar, and you almost use that as a shield to hide behind to play your status game. And the point of the status game is we're always trying to work out where we sit on the hierarchy. As a result, we will tolerate a tyrant because they seem to have lots of status, and we might be able to get a bit of their status by supporting them. Similarly, we will accept our subordinate position because we are built around the status idea. There are many marshmallow experiments out there, and I'm very reticent to just throw psychology examples out at people. But the idea that teams are given uncooked spaghetti, scotch tape, sellotape, and marshmallows, and they're to build a tower. Structural engineers are very good at this. Kids are very good at this. Adults of every profession are terrible at this because they spend all their time arguing over who's the boss, who's the follower, who will take the fall if something goes wrong. In other words, we play the status game, and look at most of the meetings that we go to. They're not to get anything done. They're either to fill people's calendars or to work out where everybody is on the status hierarchy.
Simple question, Dr. Brindley. How do you fix that? How do you... I mean, we're going to get onto solutions in a bit in general, but in terms of status, how do you fix that within your organization?
Well, step one is accepting that that's a real thing. If somebody's heard about the status game for the first time, pick up the book and accept that you are unconsciously playing that game. And then what do? You accept that some days you'll win and some days you'll learn. And I worry that as a culture, I see people making every hill a hill to die on. The give and take needs to be brought back in. But again, that's about, if you have a relationship with somebody, there's give and take. So you'll say, Brindley was having a bad day. I know he's a good guy ultimately. One of the light bulb moments for me was when somebody pointed out the difference between nice and kind. kind is doing the right thing, especially when nobody's watching, and especially if there are consequences to you. Nice is performative, saying the right thing or liking the right tweet, and then potentially gossiping behind people's backs. And gossiping's a pretty pernicious thing. I mean, I've heard it described as bullying when the person's not even present. Now, bullying as a term is a whole different talk, and professionalism's a whole different talk. And I worry that we throw the words bully and non-professional around way too easily. And in fact, what you mean is the person was excessively forthright or discourteous or a dick, I don't know if you have to edit that out. But the point being, don't go straight to these top shelf words like bullying and not professional, especially for somebody that's dedicated their life to being a professional and given up many of their hobbies and their weekends and potentially damaged their relationships to do this job. Don't take the only thing away from them and call them not a professional. Just sit down with them, take the time, point out one or two things they do well, but point out that to be more successful in the future, they're going to have to mollify some of their personality traits, or simply point out that the world has changed. Do I sound like I'm trying to counsel myself as I say this? Because that would be accurate. The world has changed. And some of that change is for the good, and therefore I have to get behind it. And some of that change I'm not very excited about, and so I am going to respectfully, persistently remain engaged and push back so that there's a dialectic.
That was a brilliant way of touching on a touchy subject.
Dodging the question.
And I do like the difference between nice and kind is a very interesting thing to reflect on. So there's so much packed in there in terms of professionalism and status. Any comments there?
For me, it really comes down to the whole communication skill and communication again. Within a team, having the safety within a team where there's good feedback, where you have moments of briefing, debriefing, and building that into the culture, I think would be the underpinning that I find incredibly important.
Yeah, I know at our hospital we do have workshops on how to give feedback. Certainly we have simulations. I mean, these are all things that I think we should try and take every advantage of participating in, because again, these things aren't going to change overnight. It definitely takes practice to give good feedback. It takes practice to bolster up your communication skills in a way that you're going to avoid the poor verbal, paraverbal, and nonverbal communication screw-ups that we all probably too often do.
If I may, though, Anton, rather than waiting 30 years, we can all develop one-liners, genuine, non-contrived one-liners. So, for example, I still talk somewhat like a Brit despite working in this system for 30 years. My sentences do not go up at the end in the sort of typical Canadian style. And as a result, they sound overly dogmatic, bombastic. Now, we all know the expression, I don't mean this to sound offensive, or I mean this with all due respect. Now, that expression has been used so many times, it now means the opposite. You think, oh, God, I'm about to be shown disrespect. But to learn lines like, hey, can I try again? I think I came off the wrong way. Or, oh, that one's on me, guys. I'm tired today. Or, sorry, I'm a bit punchy. We have no beds upstairs, but that's no excuse. Let me try again. Learn some lines. Learn to apologize. Approach people after the fact when it's cooled down. And by the way, work out whether they're a person that wants to talk about this right now, which is me, because I'm terrible if things stew, or whether it needs some time. So I'm a guy that gets an email saying, we need to talk about bed 15, but let's do so in a week. And I spend that next week thinking, what's this all about? What's this all about? Whereas other people say, let's not talk about it now because it's a bit hot. Let's talk about it within a week's time. And you need to work out your audience too for that feedback.
Yeah, I find even just a couple of weeks ago, I was in a resuscitation. This happens to me probably every 2 or 3 resuscitations where I get a bit short with people, I fully admit. And just having that self-awareness that you realize that you were short with someone is the first step, I would think. And then I find it invaluable to immediately, and the quicker the better, the sooner after it happens, the better, immediately after the patient is stabilized, to then address the person who you were quick at and say, and again, just apologize. It's very simple. You just say, oh, I'm sorry, I was a bit short with you there. It makes all the difference in the world, because that little utterance that you made that was perhaps interpreted as short that can ruin your relationship with someone on your team for years.
As I say, for 10 years. And what we have to stop doing is doing an assessment and saying, well, that person was more than 50% responsible, therefore I'm not apologizing, because that would be me giving up status. Nye Bevan, the guy that started the NHS, argued that seniority and leadership, the value of it was you were now able to give away power. And it's a pretty deep comment. It's not to retain power, it's the ability to now magnanimously give it away. And instead what we do is we say, no, he was mostly responsible, so he gets no apology from me. What I try to do, and fail, but what I try to do is say, I'm probably 10% responsible, so I'm going to apologize. Now, I'm not going to go in with mitigating statements like, it's mostly your fault, but I could have done this better. I just go in and I say, you know what, I could have done this better, I'm sorry. And if that person wishes to apologize for what I have decided arbitrarily and probably inaccurately was 90%, then probably wasn't. Whether they want to apologize or not is out of my control. I am getting more and more into the Stoic philosophy, Anton, and you know, I can't control what's happened, but I can control my response, or at least I can strive to.
Absolutely. I want to circle back a little bit to feedback. You know, we tend to think of feedback in terms of constructive criticism and how to give constructive criticism, but from my personal experience, I make it part of my regular practice to give positive feedback where positive feedback is due. For example, I would say every 3 or 4 or 5 shifts, there's an incredible triage note written by one of our incredible nurses that is just so perfectly detailed and really makes my job so much easier and is just so well crafted, especially considering that our triage is usually slammed with massive volumes of patients, very high stress situation there in triage in our emergency departments. And I will take 1 minute, and that's all it takes, and go to the triage nurse in the midst of all the chaos there and just tell them. And it's funny, usually what I do is I say, who wrote this note? And, you know, they think, oh, someone's in trouble, because that's what they're used to hearing. And then I say, oh, this is one of the best triage notes I've ever seen. It made my job so much easier. Thank you so much.
Well, I like the attention getter. You're a skilled communicator, so I know what that does. And that's almost like humor, where you set up tension and then release tension. But you know what? Having an ordinary day is something that deserves recognition and celebration. And the danger is we go, hey, that was a good day today. And the person says, what are you talking about? Oh, you did well today. And they say, what are you talking about? Everything went fine. Nothing happened. Exactly.
Yeah. I mean, you know, as humans, we do this with ourselves too, is, you know, we go and see 20 patients and then we don't think about the 19 that went really well. All we think about is the one that went badly. It's totally our human nature, and it's true with other people as well. You know, another example is I regularly celebrate our wins, especially in the resuscitation room. Again, 99% of the time, we're saving people's lives and doing amazing things in the resuscitation room. I try to remember at the end of most of the resuscitations, I say, congratulations, everyone. Another life saved. That was awesome.
Yeah, and a couple of points I'd add to that. You know, there's safety one, the whole science of stopping people doing things that could harm people. But there's also safety two, which may be our salvation and the way to empower people who are feeling unengaged and burnt out, which is exploring how, despite complexity and chaos, good things still happen and people work out how to keep people safe and how to keep the team resilient. Now, it's difficult. Like a drug, compliments also need to be dosed. A little goes a long way. And if everything is being complimented, it's almost like school where everybody gets a medal, so therefore nobody really gets a medal. So it's a very difficult thing.
I would argue, actually, Dr. Brindley, it's not so difficult. I agree that if you just do it too much and it's not sincere, then it's diluted. But if you give praise where praise is due, then I think you really can't go wrong.
I guess all I'm saying is I was around when the sandwich technique was first introduced, and it was a terrific idea for about 2 years before it became so hackneyed and cliched that people weren't listening to the compliment because they knew the criticism was coming. And then they weren't listening to the last comment because they were still focused on the criticism. And equally, it gets to the point occasionally where people sort of don't mean it, don't want to do it, but they just emotionlessly go through the sort of, I really like the shirt you're wearing today, but that patient care didn't go well. But back to that shirt, it really looks good on you. So I think we're on the same page, Anton. Sincerity is incredibly important. And if you're known as somebody that compliments a lot, that will be appreciated. If you're known as somebody that doesn't compliment a lot, it doesn't mean you have to immediately start contriving compliments, because the compliments that you give, when you give them, will be seen as genuine. And it's verbal, non-verbal, paraverbal. They'll be the way you said it and your intent. And when you just quietly slide somebody your credit card, go get breakfast, or go get everyone coffee, and you know what? Don't come back for 15 minutes. That's a tough interaction you just had. Take some time for yourself, and we'll have a sit down and we'll have lunch later. I guess what I'm saying is there's many ways of giving compliments and showing people that you care.
I totally agree with that. I'd like to move on to the communication with consultants that we so often have. And I would say the same thing applies to consultants in terms of giving positive feedback. I don't think we do this enough, is when I get help from a consultant, and that's really excellent, genuine help that has really helped me and my patient, I thank them for it sincerely. And that, again, goes so far to developing great relationships with your consultants and improving the culture in your hospital. If everyone did that, that would help improve your community and your culture in your hospital. But all too often, we do get pushback from consultants. There's all kinds of examples of teamwork in our hospitals. There's teamwork in resuscitation, there's teamwork with our trainees, and there's teamwork with consultants. And where I work, we have excellent relationships with our consultants. And when we call for a consult, 99% of the time, in my experience, the consultants are helpful, reasonable, and collegial. We're happy, they're happy, the patient's happy, and imagine the patients probably have better outcomes in general because of the excellent teamwork at the hospital that I work between consultants. But my understanding is, of course, that isn't true at all hospitals. I've actually always been totally dumbfounded by the notion that trainees are trained by their staff to avoid consults and push back at every chance they get. I mean, it's exactly opposite of what they were trained to do. We're trained to assess patients and take care of them, and here they are doing everything they can to avoid seeing the patients at all. So, Dr. Byker, can you shed some light on why this is and how we can change this culture of pushback from consultants?
Well, Anton, it's such a great question. And I wish I could just ramble off 10 reasons why this is happening and then give you 2 solutions to fix it all. This is something that really has been sort of close to my heart, because I've been in my training throughout, from South Africa all the way to what I've done in Canada, training as a specialist, internal medicine and critical care. I've certainly been at the receiving end of, grumpy consultants, but dare I say, I've probably also been the one dishing it out at certain times. I should shamefully add. I don't know why this is happening. Is it because consultants are perhaps uncertain in their skill at certain times with certain problems? Could it be the fear of litigation or adding more responsibility, adding more risk of litigation? Is it because they're really unhappy in their role? Are their cups not filled? Are they burnt out completely? Are they overworked, under-resourced? Or is it all of the above? I really don't know. But it has certainly led me to reflect on my own practice. And a consultant that I worked with in South Africa, a cardiologist, who was, as Peter mentioned, perhaps one of the silver-haired or grey-haired people, taught me one thing. And that is, if you get a phone call as a consultant, there's 2 people on the other line that need your help. The first is, of course, first and foremost, the person at the center of our team game, the patient. But then there's also the physician who has perhaps reached the end of their training or has now reached the point where this patient now needs to be referred for further definitive management, etc., etc. So That really is a very helpful thing to think about every single time that my pager goes off. The second thing I think was just being mindful. Reflect on your own behavior. Are you being a jerk right now? How are you communicating? How is your communication coming across? I think if those two things fail, the last thing that I would really appreciate, and this is about the feedback and the feedback culture, is that I would love to hear from colleagues in the emergency department how my behavior was, how my behavior has influenced patient care, and how my behavior has influenced my relationship with them, if it was a particularly bad interaction. Equally, if it was a good interaction, because that really underpins a lot of good things in teamwork as well. It is incredible to be known that you are valued as a consultant. So equally important, if things went well, I would love to hear that as well. That creates engagement. It really underscores the teamwork thing that we've been speaking about. Those are my thoughts on it, and I'm sure that Peter can add a lot.
Well, I think, Anton, it's a fantastic question, and you've very politely distilled so many of the problems that we face on a daily basis. There is toxicity in work environments. I've been down in the emergency room as an ICU doctor waiting for a callback and therefore had a few moments to observe the interactions going on down there. And you poor guys from Emerge, you are on the phone constantly begging people to come down and see the patient. It's ridiculous. You're having to sell the patient as if you're a bad secondhand car salesman to try and get them interested. And the person you're speaking to is often sort of thinking, but what about the troponin? Oh, good, no longer my problem, that's cardiology's problem, rather than what can I help with? We introduced a kick-ass award. That's actually what it's called. And once a year, one person gets a prize for just being a great colleague. Now, we also, all of us have a bit of a hero narrative where we think the world has almost sort of conspired against us, That patient with a CHF who didn't come into the hospital because they were short of breath, they came into the hospital just to make my day worse. And we have to get past that. It's about the darn patient who needs some help. We've almost got an addiction problem to status, an addiction to importance, an addiction to our own narratives. And we almost need to do a 12-step program and apologize first and acknowledge what we've done and realize some of our behavior is out of our control, so we need help from others. And if you go through the whole 12-step program, you eventually end at serving others. And we need to reintroduce this so serving others doesn't seem like it's a mug's game, that it's actually why we got into the profession, and it is the most important thing.
Some of the specific things that we've talked about before on EM cases in terms of communication with consultants, the one that I find to start off is just simply saying, thanks for taking the call.
Yep.
And I think that's much better than, I know you're really busy, sorry for bothering you. If you really need this person's help, just simply say, I need your help. It's very hard for someone to say no to, I need your help.
So why don't we go through those, Anton? Because you're absolutely right. I need your help. I could really use your help. Thanks very much for taking my call. Works so much better than you have to take this patient. Now, maybe entirely accurate, but it encourages a dogfight where people start doing that. I'll show you, no, I don't, and you don't tell me to operate.
Yeah.
And so what have you heard and what have you said that has worked? Because I find I've got a really interesting case for you. Really sounds like a one-liner too.
Yeah, that one doesn't really work very well.
I'm smiling as I say this.
It does not.
No, but then the other ones, I think that this patient would really benefit from your expertise. Again, bringing it always back to the patient rather than the fight between the consultants. I think this patient needs your help.
The problem is a script will become old fast. And each line we use now, in 2 years from now, will be a cliche where people think, just a second, that's the line they use when they're trying to bamboozle us. So we just have to be dexterous enough to keep updating.
Absolutely. Well, flexibility is the name of the game in emergency medicine and in the ICU as well.
Indeed.
So that's a little bit about how we really need to change the culture and how we communicate with consultants. The other culture that is very strange to me is what I've heard from other hospitals again is, and I'm just going to say it bluntly, treating trainees like slaves. So again, where I work, the trainees repeatedly tell us that their favorite place to train is at our hospital because I think the teaching is quite good. And like we have relationship with our consultants, everyone seems pretty happy. And at our place, I think there's huge advantages to treating your trainees really well. Because if we treat our trainees well, then we become the most popular place for where they want to work. And then we get the best choice of the best trainees to work in our emergency department. I have heard at other hospitals from other colleagues that literally trainees are treated like slaves and do all the work without much kudos at all. And so any thoughts about the culture of how we treat our trainees and how we can improve that culture?
There's an old line that hurt people hurt people. And so if you've got a culture where people were beaten up, when they get into positions of responsibility, they'll likely pass that behavior on and assume that's normal. There are vicious cycles where bad behavior begets bad behavior, doesn't attract the right trainees, and so as a result it just gets worse and worse. And virtuous cycles, like you say, you attract the best trainees want to stick around, they further enhance that culture. And we all know hospitals in our cities that have better and worse cultures. That's why they say break the cycle. Every one of us has work to do to be part of culture. As I said at the beginning, culture isn't owned by any one person. It's owned by all of us, and thank goodness. So we all have a part to play.
Yeah, I mean, the mere fact that you would refer to a resident as slaves or even have that mindset indicates that the agency is completely taken away from that resident. And I think for me that's what it comes down to. That person is there to learn, they're there to train. Yes, it does imply that there's going to be lots of work to be done, but it does not imply that they have zero agency, that they have zero say over what happens, that they have zero say over the hours perhaps that they work or even the scheduling. So that is the culture shift that needs to happen in a place like that, because there is no good outcome other than that culture being perpetuated, in my mind.
Yeah, I think empowering trainees to make decisions about their scheduling, etc., can really help in that culture as well. Rather than just always being told what to do, at least been giving some choice. And I try and do this with my trainees all the time. There's a few different patients to be seen. Which one would you like to see? What would you try and like to learn? Giving them choice helps to alleviate that notion that they're treated as slaves. I want to switch gears a little bit. So, Dr. Brindley, you had touched on the idea of learning, earning, and returning and how that changes through our career. I want to dig into that a little bit further. In a book called The Second Mountain by David Brooks, he talks about surrendering to a life of commitment once you've climbed the first mountain of building your career for a fulfilling career. Can you explain how our thinking changes as we develop through our careers and what this has to do with culture?
Yeah, and it's a great book, and pretty much anything by Brooks I would highly recommend. I'll add a little bit, though, to that analogy that between the first mountain and the second mountain, so first mountain all about external validation, being recognized, climbing the totem pole, and then the second mountain, if you're lucky enough, you get to climb the second mountain. The second mountain is about internal validation rather than external validation, doing the right thing when nobody's watching, giving back to your system. So I'm not suggesting learning, earning, and returning is one followed by the next, followed by the next. You don't spend your entire first third of your career learning and not caring about the other aspects, and you don't only serve at the end. So you can do this within a week, you can do this within a month, you can do this within a year. You just better do all three. But the fascinating thing about the two mountain model is there's usually a crash between peak 1 and peak 2. In other words, you drop down the side of the mountain too. And that's burnout, or that's your crisis of faith. And the crisis of faith term is a suitable one because work is a modern day religion. And so if you lose your faith, i.e. your job, that can feel pretty darn crushing.
Yes, I do recommend that book by David Brooks. Again, it's called The Second Mountain, especially if you're sort of in your mid-career, especially if you're feeling burnt out. This can help you redirect your goals in your career. And now a word from one of our sponsors, Easy Resus, the resuscitation assistant. Easy Resus is thrilled to announce that they are now available for institutional access. In addition to providing the app for all employees in your organization, this means access to exclusive features like printable protocols with calculated medication doses, customizable content to fit your local protocols and practices, access to Easy Resus on computers via the web-based version, and much, much more. To learn more, visit the institutional license section at easyresus.com. And as always, you can download Easy Resus and use the promo code EMCASES, that's EMCASES, one word, to get your 2-month free trial on an individual subscription. I want to switch gears again to a very specific topic, and that is death and dying. And this one, culture has so much to do with because it's one's general culture that they live in that plays upon this, as well as the culture within medicine. And things are evolving over time. Over the last few decades, things have evolved in terms of our view on death and dying in North America, at least. You know, I remember many years ago, I was sitting on a rooftop restaurant by the Ganges River in Varanasi in India, which is considered by many people in India to be the holiest place in the world. And I noticed while I was eating breakfast on this rooftop terrace that a whole bunch of surrounding rooftops had dozens of older people in wheelchairs chatting and looking like they were having the time of their lives. And I asked a local about what was going on with all these rooftops filled with these disabled, older looking people just like partying their butts off. And she explained to me that they all knew that they were going to die soon, and that they just felt so fortunate and happy because they were going to die by the holy Ganges River, and this was the greatest way of leaving the world. And I've seen many a nursing home in North America, and we're sending people to places like long-term care facilities all the time from the emergency department, and it was just such a huge contrast of how we deal with death and dying in North America to what was seemingly happening by the Ganges River in India. And that's stayed with me since. And I'm always kind of struggling with how to deal with death and dying. And then in the emergency department, especially when literally we've just met a family and we don't really understand their cultural background. And then there's the culture of the hospital, and then there's the legal issues. It's really quite complex. And the two of you being intensivists, you probably have even more experience with dealing with death and dying than any emergency physician. So could you give us your take on what you think the culture around death and dying should ideally be in North America and how we should get there?
Well, thank you for bringing up this topic. It's an incredibly important one. I'm the son of a palliative care counselor. I'm the son of a biochemist. My mother was a palliative care counselor. The poor lady died of Jakob Creutzfeldt. I saw firsthand that she didn't get the death that she wanted or the death that she deserved, despite a system that biotechnically was top-notch. What it hadn't done is put similar effort into the pastoral aspects, palliative home care, holding hands, looking people in the eye, asking them how they're doing, making sure that there was still joy in their life and that they still felt engaged and they felt cared for. Instead, these discussions all got lost in, symptom control and this medicine, and perhaps we could try this. And so we are all going to die. I know that's been said a million times, but it almost feels to me like it needs to be emphasized over and over and over again, because every ICU doctor has heard a line along the lines of, doctor, death is not an option. And it's everything we do to hold back from saying something dismissive like, yep, it's a certainty for every one of us. It's just when it occurs. And we don't want to say things like that. And we don't want to come across as world weary or nihilistic. And in fact, there's a danger in my specialty that you'll have two types of people: those that just become overly nihilistic, and those that just beat themselves up and suffer a great deal from the moral distress. Now, we need to take pride in these conversations. As I've alluded to, and to borrow from Dan Howes, the communication that we do, that's the most important medical procedure. And it's potentially the most meaningful, and it's potentially the most dangerous. Goals of care, just trying to summarize an 80-year-old's glorious life with its ups and downs, challenges bested, that to me has always felt, it's better than the binary of do everything, do nothing, because those two extremes don't summarize where we're at. But similarly, you almost don't need that form if you have a relationship with the family. They'll understand. And if you don't have a relationship with that family, that form is not going to solve all the problems.
Well said. Dr. Byker, any thoughts in terms of how we get there, in terms of improving our culture around death and dying, both generally speaking and in our hospitals, and what we can do at the bedside to help with this?
You speak about culture around death and dying, and the first thing that comes to mind is our culture at large. And I really need to borrow here from Blair Bingham in his book Death Interrupted, where he describes perhaps the reasons why the culture around death has changed. And one of the things that he mentioned is that we have institutionalized death. People no longer die at home. We no longer have an old, frail person, perhaps, in our homes, that just slowly deteriorates and passes away comfortably. Somehow we've gotten to a position where the inevitability of death needs to be accompanied by heroics. And I think, if we can somehow change that in the communication around that, I think that'll go a long way. And I used to be a primary care physician as a GP, and I can probably count on one hand how many times I actually discussed things like this with my patients, and perhaps bringing up that death is inevitable, that your comorbidities is such that should you become gravely ill, the outlook may not be as good. And so that I think would be one of the places to start with, is teaching this in primary care, perhaps, if it's not already taught, and really emphasizing that. I think our jobs, to the second part of your question, how do we change the culture within the hospital? I think our jobs are very different. In emergency medicine, you don't always have the time to go through all the all the difficulties, I should say, of what's happening with a patient, and seeing the bigger picture, because somebody is actively dying in front of you, and you have to act, you have to do what you are trained to do. And so often that's then where ICU picks up that ball and runs further with it. And I've often heard it said that 2 weeks of ICU care avoids 1 hour of difficult conversation. The truth is 50% of our job is conversation, and difficult conversation at that, with families, whom we, by the way, meet at their worst. And again, here I have to borrow from one of our colleagues, Dr. Sam Shemi, out in Montreal. If you consider all the things that we can do to people, all the technology that's available to us, yes, it's there, but is it something that we should be doing in all cases? And he has the 3 T's, which I really love. The one is there a treatment that's going to fix the patient? Is there time that is going to fix the patient? Or is there a transplant that's going to fix the patient? And if none of those things are there, then we may be steering towards futility, and phrasing things to patients, families, in such a way that, that really tells them that their loved one is at a risk of dying. Saying something to the effect of, your loved one has become so sick that I think that they are at a very high risk of dying. I don't think they're going to survive. And setting up that conversation, and it takes time. It's not a quick conversation within an hour, boom, you're done. It may take a couple of days to try and meet families where they are. Sometimes with ICU care, we can add a few weeks, a few months, and that may very well be what that family needs in that time. The loved one that is critically ill may just need that time to see a daughter get married or something to that effect. So it really is always a moving target. It's always a conversation, and it's always a conversation where we as healthcare professionals really need to meet the family where they're at and also meet the patient where they're at and try and get a realistic conclusion.
Yeah, I find one of the things that may help to improve the culture around death and dying is I make it routine when there is someone who dies in the emergency department under my care that I have a 1 minute of silence with the team around the bed. And that 1 minute of silence, I really think helps the team appreciate that this is a person who has died, not just a body of anatomy and physiology.
So bravo to you, Anton. It was pointed out to me that there are 2 days in your life that are less than 24 hours, the day you're born and the day you die. And we celebrate the one, and the other one, we look at our shoes and we don't know what to do with ourselves, and we can't really contain our emotions, and we talk in riddles and euphemisms. Families talk in naturalistic language of hopes and desires, and we talk in scientific language, which unfortunately much of the time is just facts. The sats are, the hemoglobin is. And I can tell you, we read charts that are days and days and days of just no meaning, just data. And the point that was being alluded to about dying certificates is Matt Morgan and I wrote a piece arguing that the modern doctor probably needs to write something akin to a dying certificate. Now, I'm not talking about a literal dying certificate. I'm talking about clear communication that says this patient is dying, we're trying to find them extra time, or this patient, as Leon said, has every likelihood that they could die, we'll try, but we may be unsuccessful. In the old days, doctors wrote death certificates because that's what society needed, was to say this body has passed, therefore the funeral rituals can now occur. Now patients live in this liminal state, or they can live in this liminal state, between life and death, but not really either. And so what is now needed is something akin to a dying certificate. Clear communication. Now, that's a tough thing to do because either you can say prognostication is imperfect. Of course it's imperfect, but that doesn't mean it's impossible, and that doesn't mean you can't distill down all this medical claptrap into usable information. We had an interesting experience recently where Matt had a living funeral. Now, to some people, that will seem self-indulgent because you want people to say nice things about you while you're still alive. But the point is, why not do that, first of all? And secondly, the pushback from members of his community and other people who joined in the living funeral was incredible. And I find this when I talk to families. Even myself, I try to have conversations with my relatives about what is meaningful to them at end of life, and they just tell me to shut up, and that's a morbid topic, and they're too busy paying their mortgages. Now, the danger is we go too far the other way, and we become almost like grief junkies, where we talk about this too much and forget to celebrate life in the meantime. I spend a lot of time in family conferences trying to find out about the patient and what they valued, but also because I know about their lungs and their hearts and their liver and their kidneys, but I don't know about them as a human being. And it keeps me slightly more human to hear how they met their spouse and what I don't really care what they did for a living because that's how you put bread on the table, but it does inform the person that they were and where their joy and their drive came from. And we've become very mechanistic in end of life. It's sort of nothing I can do, see you later. Well, yeah, there is stuff you can do. You can dial down the high-tech, low-touch medicine and sit with the patient, get them a cup of tea. One of the worst things in COVID for this Englishman was they got rid of the tea bags. Why? Because that's how we hug patients. We get them a cup of tea. And little things like that, and limitations on visitation because it isn't convenient for us from an infection control point of view, or it isn't convenient for us because of too many people in our workspace. I can't get behind that. You know, they've been that patient's life support for decades. I've been their life support for 10 minutes. We need to, within our flashy hospitals, get families back in and get patients' values and what gave their life meaning front and center.
At the top of the podcast, I promised that we would focus in on 5 solutions on improving the culture of medicine. And we've touched on a few solutions, but what I'd like to do is kind of organize them, dive a bit deeper on them, maybe introduce 1 or 2 new ones, and hopefully they'll be practical for our listeners. So there's 5 solutions to improving the culture of medicine that I want to discuss. The first being self-compassion and being a failure friend, which we'll explain what that means in a minute. Embracing safety, changing the emotional contagion, dialing down the adrenaline, and expectations of culture change over time. So let's start with self-compassion and being a failure friend. Now, one of the most listened to podcasts in EM Case's history was Sarah Gray's Best Case Ever, number 63, entitled Failing Up. Dr. Brindley, could you remind our listeners what failing up is and how self-compassion and failing up can improve our workplace culture?
Well, I'll never do as well as Sarah, and people should take the time and listen to that podcast because it's beautiful and nuanced. But essentially, self-compassion is about accepting you will have imperfect days and cutting yourself some slack because you need to do this career for a long time. And ideas like we will fail, but fail up and learn something about it and reach out to others and build those relationships. The point that Sarah makes that I really like is that you need failure friends and you need to be a failure friend. So if you don't have any, find some. If you don't think you're one to other people, then find a way to be so. But Sarah goes more granular than that and points out you actually need to tell people what a failure friend looks like. In other words, does that person need to leave you alone for a bit, or does that person need to actually turn up at your back door? Does that person need to get you a cup of tea or never get you a cup of tea, take you out for a beer, never take you out for a beer because that's inappropriate? So we need to get past our emotional awkwardness and be a failure friend and accept a failure friend, but we also need to get more granular and say what that looks like.
Absolutely. I mean, I've had experiences in the past where I've been a failure friend to others, and I've had others be a failure friend to me, and it is invaluable. So I do encourage people, we've all made mistakes in our careers. They sometimes sit with us for too long and eat away at us, and that can certainly, lead to burnout and impair our ability to be compassionate and communicate well with others and help to ruin the culture of medicine, especially if everyone is like that. So yes, that's the first one, failure friend. The second solution I wanted to talk about was embracing safety. So Dr. Brindley, could you elaborate on how embracing safety can help our culture?
There's small s safety and there's big S safety, first of all. So we all have a part to play in culture. We all have a part to play in safety. I alluded to the safety 1, not making mistakes, and the safety 2, exploring the things that keep people safe and teams safe and implementing those too. So safety is no accident, as the old pun goes, but it's also everybody's responsibility. Now, part of safety is feeling safe, to give feedback, take feedback. And there is a lot of paranoia in our profession, and there is a lot of worry that, they're going to kick me out and they're going to sideline me. And that's where a lot of the burnout that other people have talked about comes from. So part of safety is also feeling safe. And I mean emotionally safe as well as physical safety. But for you in Emerge, there's even the quite literal issue of physical safety.
Yeah, I like the definition of safety as the study of how things go right despite a difficult, chaotic environment.
And that's definitely safety too. Absolutely. And there should be more of it.
Yeah, there's the Ottawa M&M framework, which was developed probably about 15 years ago, which we like to use for all our M&M rounds, which really directs any mistake made away from the individual and looks at all the systems issues and all the factors at play that lead to a bad outcome. And I find that's invaluable, especially compared to the M&M rounds that we used to have 20 years ago, where it was all about blaming an individual.
Naming, blaming, shaming. Absolutely. We've got to move past that.
All right. The third sort of action item or solution I wanted to talk about was changing the emotional contagion. And Dr. Brindley, you had talked about this before. We've all seen bad communication, both nonverbal and verbal. Can you give us some tips on how to actually change that rise in emotional contagion?
It's a tricky one, isn't it? Because we're all on edge, or we think we're all on edge. And so I think it's back to that Viktor Frankl of take a moment, take a beat. I think as you get further on in medicine, you do start to realize we do have a moment to think here. Just give me a sec. Let me get my thoughts straight. Okay, now we can proceed. And there is a danger of sort of, it's got to be done now. And I don't even care if it's the wrong thing to do. It's the expeditious thing to do. So let's just do it. So again, we all own the culture. We all own the emotional contagion. It's why people like Liz Crow have pointed out, in terms of burnout, you define burnout, you point out that it's a very understandable reaction, especially for a mid-career person who sort of feels too far from the beginning and too far from the end, and so just feels resigned to their fate. But the minute you've defined it, you then have to pivot into solutions, because otherwise you're just going to have people saying, oh, well, I'm terminally burnt out, and it's not terminal. Or, oh, well, that's just who I am. There's nothing I can do about it. Well, no, there is. But other people need to know that's how you feel, and you're not just being grumpy or dickish or all the rest of it. The Venn diagram between culture change and dialing down the emotional contagion is a very tight Venn diagram.
Yeah, I came up in my reading with this very nice list of how to change the emotional contagion should it arise. One was to be consciously aware of your own mood. If it's not one that will be useful to your team, then change it. To use nonverbal behaviors to communicate emotional contagion. To make eye contact with everyone on the team. To neutralize a negative team member. And to create a positive emotional culture within the team.
Bravo to every one of those.
Yeah. Any comments about any of those? For example, the neutralizing a negative team member can often be a challenging one. Any tips on how we can do that?
It sounds slightly Stalinist, but I think I understand that it means take somebody aside and in as empathic way as the time will allow, say to them, hey, you got a moment? I care for you. You doing all right? Now, again, we have to be very careful that they just don't become a bunch of one-liners. I'm concerned for you, so that's why I'm taking you off work. Well, no, that you wouldn't do that if you were concerned for me. You'd sit with me and comfort me or see where I'm coming from and see whether there may be two sides to their stories. And we also have to be both afferent and efferent here. We have to both be part of the solution by listening to others when they give us feedback and do the hard work of giving people feedback too. Because there is a danger that people whose behavior is seen as errant are just ignored to death. They're just pushed to the peripheries and disengaged. And then we use all these buzzwords of empowerment and engagement, but we sideline these people. And buzzwords become weapons pretty fast. People who are appropriately frustrated with a system have been called burnt out to silence them. And people who are actually feeling depressed or suicidal have been minimized by being called burnt out. And so we have to use these terms appropriately. We're medical people. We need to use our medical words appropriately.
Yeah, this brings up the idea that we had touched on before of professionalism. Mm-hmm. And I remember as clear as day, the first day that the late, great Dr. Paul Hannum spoke to our ED group, who at the time was having some interpersonal issues amongst our team. And Dr. Hannum was the chief of the ED at North York General at the time. He's the one that was an Olympic athlete and tragically and suddenly died at the age of 50. He was a close friend of mine.
Oh, I'm sorry.
And he said to our group of 60 docs something like, I don't expect you to like each other. It's impossible to get 60 people to all get along splendidly and like each other, but I do expect you to be collegial.
Bravo. I was honored to give a lecture named after him, and these are clearly the qualities that we need in our system. And each of us needs to find in ourselves, and we have them in ourselves. The problem is we may have been trained in a system that was a bit toxic. We may have been trained in a culture that's all about the individual triumphing over another individual. And in fact, for those people looking for a legacy, the best legacy you can leave, I mean, all I want people to say at my funeral was he was a good guy. And that's sort of the same that I want people to say at my retirement do. I don't want my retirement do hosted in a telephone box, because that's all the space we need, or people uttering platitudes. And so we all have a chance to work on our legacy every day. And Paul Dr. Hannum, who we lost early, but you can imagine that those same qualities would have been developed as training as an Olympic athlete, of resilience and not blaming others and turning up when you don't feel like turning up and bringing your best self forward. These are all things we should do, every single one of us.
So far we've talked about self-compassion and failing up. We've talked about embracing safety as a solution. We've talked about changing the emotional contagion as a solution. The next one I wanted to talk about, which you touched on earlier, Dr. Brindley, was dialing down the adrenaline. Do you have any practical tips on when you feel that adrenaline building up inside of you to actually dial it down?
Yes and no. And I think I've had to accept that I sometimes like being amped up. And I think emergency departments sometimes like being amped up. I've noticed this. When you go into the anesthesia environment, they love things to be serenely quiet. And when you go into emergency, there's almost people who want to amp things up, and ICU sits somewhere in the middle. And if we want an anesthetist to come and help us with our airways in the emergency and in the ICU, we sometimes have to just dial down the verbal adrenaline. Now, I've had a couple of near-death experiences in my life, and they've caused me to do a lot of reflection. The interesting thing is, during all three of them, maybe I need some new hobbies, I've been very, very calm. But when you feel your cognitive bandwidth is under threat, one of the simplest, or one of the reflex responses, is to get amped up. And so you shrink your own cognitive bandwidth. You're not as open to feedback. Your visual acuity fails. Your hearing acuity fails. You're very likely to just go to any response, even if it's the wrong response. So these are dangerous situations. So we all have to have strategies. So people talk about square wave breathing. It is just taking a breath in, holding that breath, and then slowly breathing out. And in fact, that breathing making you more relaxed, rather than the other way around, which is, you can only breathe that way when you are relaxed. It can actually slow things down. Lots has been published on a pre-primary survey, things you can do before the patient arrives. Go take a pee, have a sip of water, gather your team, pre-assign roles. All of these things are a perfect opportunity to tell people that you care about them, you want them there, you value their input, it's a safe environment, but also to expand the team's cognitive bandwidth, because everybody knows their roles ahead of time, and everyone knows that the patient's at the center, and everyone knows the out. In other words, are we keeping the patient here in emergency? Are we getting the patient to the OR as quickly as we can? Because that's the other thing, that we sort of resuscitate with no endpoint. And that causes, okay, what the hell are we going to do now? Who's going to take the patient? That becomes the sort of, once the resuscitative adrenaline has dropped, then we just get angry in all sorts of other ways. We notice this with our families, where families can hold it together during the acute crisis, and almost they recognize the patient is getting better when we do, because then the interactions become far more emotionally charged. And I think our teams do exactly the same. So you can pre-plan, you can do things for yourself, you can do things for the team, you can do things for the environment. And we wrote about this in something called a pre-primary survey. Cliff Reed is the first author on that paper. But take a beat, recognize your own emotions, as you alluded to. Step away from the situation if you can. Use your elevator thoughts. For a guy like me coming down from the ICU, I've got no beds, oh God, another call from the emergency room. Just take a moment and say, that's wrong. That's not how you should be. Your job is not to go down and try and talk them out of an admission. Your job is to go down and honestly assess what the patient needs from you. But use that walk, those elevator thoughts or the drive in from home to calm yourself down, to rehearse things, to expand your cognitive bandwidth by mentally rehearsing, not just the resuscitation, but also the team interactions you're going to have. I think we can easily dial down the adrenaline.
So much reviewed there in just a minute or two. Excellent. All right. The last item I wanted to talk about in terms of solutions for the culture problem in medicine was the idea of just taking one day at a time. We had mentioned that it takes 30 years to change a culture, but we can speed that up in some ways. How does sort of the idea of taking one day at a time, how is that a solution to culture change?
I think durable change really does take time. Hopefully not 30 years, but we live in this culture of instant answers and things that we really rely on should really be quick, and kind of that whole hedonistic culture of pleasure, and there should be no suffering and nothing should take time because we deserve everything right now. And I don't think that is necessarily true. I think we should take the time. We should slow ourselves down in everything. And it really encompasses everything that we've spoken about, being kind to yourself, realizing that you are not this perfect being, that you are going to make mistakes, and that's okay. Recognize them, move on, take feedback, give feedback, be open to change, but realize that it does certainly take time. Give yourself time to reflect, be mindful. Think about your day, think about your week, think about your month, think about your year. Where's your career going? Reflect on conversations that you've had with families. How can you do it better? How can you, iteratively improve little bits at a time? 1% change today is 1% that you didn't have yesterday, but it takes time.
If I may just add one thing, there's a lovely old line that says we overestimate what we can do in a year and we underestimate what we can do in a decade. Maybe we can change that to a day and a week and a year as well.
No, all good. What a wonderful way to wind down towards the end of the podcast. So we've covered how to define culture. We've talked about death and dying. We've talked about communicating with consultants. We've talked about trainees. We've offered up 5 solutions and touched on self-compassion, being a failure friend, embracing safety, changing the emotional contagion, dialing down the adrenaline, how we should expect culture to change over time. So before I leave our listeners with a quote from George Bernard Shaw, I do want to let our audience know that these 2 wonderful human beings do have this incredible podcast. Dr. Brindley, do you want to tell us a little bit about the podcast that you've dedicated so much time and energy and passion to over the last few years?
Anton, before we go, it's been an absolute pleasure to talk about these huge topics, and I hope the conversation never stops because there's more work to be done. But we do have a podcast as well. We are but minnows to the whale that is yours. Very admirous of the work that you've done. Ours is called the Critical Care Commute, the idea being 20 to 30 minutes on a topic during your commute to or from work. And hopefully, much like every podcast, the right mixture of steak and sizzle where we cover factual stuff, but we also cover these bigger topics and highlight important people.
Yeah, it is an excellent podcast that really digs deep into some topics that are not covered anywhere else, especially ones like this that we've talked about today. And so, as I promised, we've got a quote from George Bernard Shaw that we'll end the podcast with. And here it is. True joy is being used for a purpose, not a feverish, selfish clod of ailments and grievances. Complaining the world does not devote itself to making me happy. Life is a splendid torch which I hold for a brief moment. I want to make it burn brightly before handing it to future generations. Thank you very much, gentlemen, for your insights into the culture of medicine and how we can improve the lives of physicians, nurses, paramedics, PAs, and of course, our patients.